Welcome, everyone. Today we are going to be reviewing antibiotic stewardship in long-term care. So this is about protecting our residents, improving outcomes, and staying survey ready. So this is not as complicated as people may think. So what we're looking to do is protecting our residents, preserving antibiotics, and practicing smart care, right? Does the resident meet criteria? If so, then what? If not, then what? So this PowerPoint is going to talk about what we do when it's appropriate and what we do when it's not appropriate. And this PowerPoint can be um, used for providers, for patient education, and staff education. So why does this matter? Well, antibiotics are commonly prescribed in long-term care, but many may be unnecessary. Overuse of antibiotics increases C. diff, causes antibiotic resistance and adverse reactions, which we'd like to avoid. Sometimes there's other things we can do instead of or before starting an antibiotic. So our goal is smarter, safer prescribing. So if you stop and think about it, 50 to 70% of long-term care residents do receive antibiotics every year. That's quite a bit. To 75% of these are usually inappropriate. Overuse leads to obviously what I just said, C. diff, MDROs, adverse reactions, and the body's unable to clear infections on its own. I mean, if you stop and think about it, our bodies are designed to fight against organisms. And if we let the body do its job as much as possible, then we can still stay healthier longer. So it's very important to focus on smart prescribing and protecting our residents. So what is antibiotic stewardship exactly? Antibiotic stewardship basically ensures the right drug, right dose, right duration, and right indication for the antibiotic. It is a coordinated team effort which involves nursing, providers, pharmacy, and leadership. So this is something that together as a team collectively, we should all be thinking about and we should all be looking at. Is it a challenge? Yes. Is it impossible? No. So some regulatory things, when we inappropriately prescribe antibiotics, it is considered an F tag, which is actually not good. F tag 81 is the implementation of a stewardship program. This says that facilities must have a stewardship program and that surveyors will review the documentation, the tracking, and quality integration. If it isn't documented, it didn't happen. How many times have we heard this, right? Again, if say, for example, we know that the patient met criteria, but somebody failed to document fully, then on paper, we do not have anything supporting the use of that antibiotic. So this is where documentation is critical in our practice for all of us, for the provider, for our nursing staff, pretty much for everybody involved. It protects you, the resident, and prevents an F tag, which nobody wants. So it's important that we implement this stewardship program, track the antibiotic use. It should be included in a copy. Staff and residents should be educated. And when we educate residents, we should be documenting that this has happened too. And we should be documenting the indication and monitoring for adverse reactions and all kinds of other things. This is not completely new information, but some of it may be. And some of it are potentially things that maybe we just didn't stop to think about. Okay. So the CDC outlines 7 core elements to a stewardship program, which requires leadership support, right? Clear accountability, pharmacy involvement, tracking, reporting, and education. So sometimes it's important also to report to the state, especially if our COVID outbreaks and all that other stuff. And what are we doing to protect our residents? Do they really need these antibiotics and so on and so forth? Sometimes they do need them, sometimes they don't. And that's where it all gets very confusing. So why is long-term care at a higher risk than others? So long-term care residents are medically complex and often have colonized bacteria. Colonization does not mean an infection. Treating colonization actually leads to harm. Why? Because of their advanced age, their comorbidities, indwelling devices, frequent hospitalization transfers, a chronic colonization, and colonization does not necessarily equal an infection. Okay? So UTIs are the most common drivers of our antibiotic use. We do not treat cloudy urine or positive cultures without symptoms. We should always be assessing clinical criteria first. There are a lot of things we can do also to help the body clear UTI. Increase fluids. We should be looking at how are they eating, how are they drinking, the overall picture. And as we know, most of this population do not drink very well, right? So again, that's what LNAs and nurses together can do to help their patients. Encourage fluids, right? So we do not treat cloudy or foul smelling urine, a positive UA without symptoms, and we treat only when clinical criteria has been met. So that's very, very important. Now let's talk about some respiratory infections. Respiratory infections are frequently viral, so we must assess thoroughly before requesting antibiotics. Antibiotics do not treat COVID or influenza, right? So assess before antibiotics. Does this person have a fever? Are they hypoxic? Is there abnormal lung sounds? What are the chest x-ray findings? Right? And again, remember, antibiotics do not treat viruses. So we have to be 100% sure that this patient has a bacterial respiratory infection, not a viral respiratory infection. And so you can see how this can get a little bit challenging and a little bit complicated, right? Skin and wound infections, different. So this is a little bit different. So skin and wound infections, you got to differentiate between a cellulitis and chronic skin changes, right? So cellulitis versus stasis. Stasis changes is your body's cardiac system just changing. And so knowing your patients is essential, knowing their diagnoses. If they don't have the diagnoses, we might want to get some testing done. And then we got to decipher whether it's infected versus a colonized wound infection. Redness alone is not necessarily an infection. Okay. So what is nurses' role in stewardship? Nurses play a very critical role, and it's important that nurses use their skills and do a strong assessment. A strong assessment prevents unnecessary prescribing. So we need to avoid sending urine for vague confusion without other symptoms. So you're going to look at, again, perform a full assessment of the patient. Then you're going to review their baseline cognition, their baseline vital signs. Is this truly new, or is this something is this normal for them? Use clinical criteria, and that is on our McGeer's form, developed by the CDC, which I'm going to review a little later. Okay, then we avoid just in case cultures. You don't culture something just because it might be. You need to have some good data in order to go ahead and move forward with a culture or a UA or anything like that. So you want to make sure constitutional criteria had been met before obtaining culture. Okay. Nurses are the first line of defense. So be thorough and make sure you have all of your supporting data. If you don't have supported documentation, then it's not okay to move forward, right? If you have a little bit, ask yourself, can I clear this and help this person clear this naturally? And just do a watch and see? Or should we keep going and move forward and pull out all the bells and stops and whistles to get this person on something? So let's say the person's met the criteria or they didn't, doesn't much matter. Either way, an antibiotic timeout is required, and surveyors are going to be tagging this more. An antibiotic timeout must be done within 48 to 72 hours after an antibiotic is started. Okay? This antibiotic timeout needs to be reviewed. This needs to be one, does the resident still meet criteria? Two, are the results of the cultures back? And does that meet criteria? Because just because you have, let's say, a positive UA, there's a certain number that the CDC is looking for to make, because if it's below a certain number, then they consider it colonized. If it's above a certain number, then they consider it treatable. And then there's other things too. So just it's very good practice to do a 48-hour timeout. Can therapy be narrowed? Or can the antibiotic be stopped, or does it need to be changed to something else? Okay. So, risks of overuse of antibiotics. And this is something a lot of people don't stop to think about. And all too often, you know, antibiotics can cause serious harm, right? Including C. diff infection, acute kidney injury, drug interactions, allergic reactions, and antibiotic resistance, which is really, really not good for a patient. Right now, we have a lot of patients who kind of have too many medications. Any patient who has 9 or more medications should really be looked at and, you know, can cause an acute injury on its own, and that's a whole other subject. Again, just keep these things in mind, that risk of overuse and why we would want to avoid an antibiotic unless absolutely 100% necessary. I would want to be confident that the antibiotic was needed. Okay, so tracking. What do? We have tracking and QAPI metrics, right? Tracking data helps us improve. Just because we got somebody on an antibiotic and they maybe didn't need it does not mean that we shouldn't be tracking, monitoring, starts, duration. Did the person get C. diff? Did they end up with some sort of adverse effect? And this all should be documented in the QAPI process and reviewed, right? As a team. So antibiotics start per 1,000 resident days, right? So if a resident has been in the building for 1,000 days, we want to look at how many times that person has used an antibiotic, say in those 1,000 days, right? Indication, documentation rate. How good are we at documenting? Do we have all the right data? Duration compliance, right? How many of these people ended up with C. diff because of it? How many people ended up developing an MDRO because we gave them too many antibiotics? So this is all part of QAPI and among other things, but it's good to know that this is an important practice and it's something that really should be looked at deeply. Okay. So now let's talk about some scenarios. This is a scenario number 1. Okay, we have a resident with confusion, no fever, has a cloudy urine. In this scenario, confusion alone does not justify antibiotics. right? Always assess other causes of a delirium first. So, should we start antibiotics? Well, no. The answer is no. Assess other causes first. Because delirium can be brought on by many, many, many things. Okay. Case number 2. A resident with a fever of 101.8, flank pain and dysuria. Should we start antibiotics? Well, yes. This meets clinical criteria. This resident meets clinical criteria for treatment because the fever plus the urinary symptoms support appropriate prescribing. Okay. So some key takeaways. Remember, symptoms matter more than lab results, and good documentation protects you and the facility. Symptoms matter more than labs. I'm going to say that again. Symptoms matter more than labs. Colonization is common in long-term care residents. The documentation you do protects not just the facility, but you as an individual. Now, stewardship improves resident safety, right? So, some questions and discussions, and I want you to get a piece of paper out and I want you to start thinking about some things. Where can we improve antibiotic use in our facility? So, this is an open discussion. I know that this is a recorded PowerPoint, but I want you to write it down on a piece of paper and put it in my box, put it in Asia's box, or have general discussions with each other because this is very healthy. Where are our challenges? How can we strengthen our stewardship in our facility? And just be thinking about that and write it all down because this is supposed to help us improve, help you guys improve, and I hope that makes sense. So now, let's talk about some McGeer criteria. This is long-term surveillance definitions, right? These were specifically designed for long-term care. They help us determine when an infection is truly present versus a colonization. Using the criteria reduces unnecessary antibiotic use. Okay, so this is used for infection surveillance in long-term care. It helps standardize diagnoses. It prevents overtreatment, and the focus is on symptoms and clinical findings, which is required, right? So here we are. We're going to talk about a UTI with no catheter. They must have an acute dysuria or a fever plus at least one of the following: new urgency, new frequency, suprapubic pain, gross hematuria, blank pain, and a positive urine culture. Okay? So that doesn't mean your opinion. You got to keep your opinion out. These have to be true facts. New urgency, new frequency. Unless you're familiar with that patient, I would not I would not jump to that. Um, for non-catheterized residents, acute dysuria alone may qualify, but that is rarely the case, right? A positive culture alone does not meet criteria without symptoms. All right. So and I have seen this recently. A positive culture alone does not meet criteria without symptoms. All right. Moving on. So a UTI with a catheter is a little bit different. So they must have one of these: a fever, new flank pain, rigors, new onset of delirium, and a positive urine culture. Okay. So residents with an indwelling character, the criteria, again, this is a little bit different. And we're going to treat these people with they only need one of these with a positive urine culture to be treated because a UTI is like a highway for infection to get up in there. Okay. So respiratory is a little bit more complicated. So pneumonia requires To treat for pneumonia, it requires a chest x-ray. You need evidence by chest x-ray to treat that, and at least one of the others. So a chest x-ray alone is not enough. You need a chest x-ray, positive chest x-ray, and at least one. A fever, leukocytosis, hypoxia, and, see, now we're getting to 3, respiratory symptoms such as cough, sputum, abnormal breath sounds. So as you can see, this can get a little bit of a challenge, but lucky for us, we have that fancy form that will help us get through this, right? So we have an updated criteria for infection surveillance tool, and that is in the Antibiotic Stewardship book. It's very important that this is filled out completely. Do not miss anything. If it's suspected, then I would hold on to the form and pass it to the next nurse, right? Till we have enough. Once we feel all the criteria has been met, you're going to take this form and you're going to give it to the unit manager for our providers to review. After the providers have reviewed and decided on the course of treatment, the unit manager will then give it to the infection preventionist to document and follow up, especially if an antibiotic is started. I hope this makes sense, and I want you to take the time to go through the antibiotic stewardship, take a look at the criteria form. It's very, very helpful. It's spelled out in black and white exactly what is needed for us to start an antibiotic. I hope you've enjoyed this, and I hope it was helpful, and thank you. Please complete the post test. That is going to be located outside of the ADNS office. And that's it.